Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming. What are you most excited about in frontline kidney cancer, briefly? Where do you think the field should go? What are you most excited about? Mike, we'll start with you.
Yeah, so there's another poster that was presented at ASCO from Sabina Sigureti that looks at some biomarkers in the Hoosier trial that looks at both the CD8 T cells and whether they're only partially exhausted and have PD-1 on their surface or have LAG-3 or TIM-3 on their surface, which makes them completely exhausted, and also potentially looks at PD-1 on Tregs, which may actually, when exposed to therapy, might make the Tregs more suppressive. And so I think looking at those type of things as potential biomarkers, one for response and one for resistance, and then putting them together, I think we have to realize there's a balance going on in the tumor microenvironment. Some things favoring a response, some things inhibiting a response. And I think we need to look at and understand that and potentially figure out adding things to anti-PD-1 and maybe anti-PD-1, anti-CTLA-4 that can eliminate some of those immunosuppressive factors in the tumor microenvironment while we're activating T cells. So I'm looking at CTLA-4 antibodies that might be Treg depleting, looking at potentially blocking other checkpoints as we've talked about and as we've done in melanoma, such as blocking LAG-3 as ways of moving things forward.
Okay. So other immune manipulations basically in the frontline setting. Pedro,
yeah, I would highlight,
about?
Thank you, Tian, for bringing it up. Your trial OPTIC is one of the exciting things. We're happy to have it in Cleveland as well. So for those less familiar, you're basically doing a molecular signature up front and you are assigning an IO-based approach, IO-IO or IO-TKI based on that signature up front. And it's so important for a lot of reasons. Number one, scientifically, perhaps will be, used in the future if it pans out, or at least will need to be confirmed. But also, it brings genomics to kidney cancer world, right? The same way we're doing in other tumors, because it will help us to all figure it out how we can use genomics with a around time around of that is actually feasible, because we cannot be seated waiting 3 months for genetic or signature score, for instance, for us to decide what to do. So from that perspective, that trial puts the right pressure in the different institutions to get the field to actually start adopting molecular profiling as part of the information that we need up front, in addition to clinical characteristics, lab characteristics, for us to better select patients. That's one. And the other one is the microbiome. So we've seen emerging data that, impacting the gut microbiome. It does have implications in the activity, or seems to have implications in the activity of immune therapies, including immune checkpoint inhibitors. You have data in lung, you have data in kidney cancer, and actually we just saw one proof of concept, a study, first with Ipi/Nivo from the Dr. Monty Paul and the City of Hope group, and with Ipi/Nivo and probiotic CBM 588, which is Clostridium botulinum, if you will. And now we kind of see the same thing at ASCO, similar results in the same line with an IO-TKI. And the results are very provocative. They need further confirmation, but I do believe we're getting this new era of learning how we can actually assess the gut microbiome. It's not easy, how to actually deal with stool samples, right? In addition to blood samples and urine samples, etc., and tissue samples. So we're actually learning a lot about it. So I do believe the field is moving as a whole, is moving, and maybe if we figured out the way to optimize the activity of immune manipulations, I think that the potential is huge. That can go beyond kidney cancer.
So biomarkers and also immune manipulation, in this case, microbiome. Tian, what are you excited about?
I can't let a first-line discussion go without talking about PDIGREE. So full disclosure, I'm biased as the study chair, but PDIGREE is a sequencing trial of sorts. So it'd be Nivo upfront and then randomized to Nivo or Nivo-Cabo, really building on Checkmate 214. And we have been enrolling for 4 years in the cooperative groups, and we are nearing the finish line, but not quite there yet. But I think once PDIGREE reads out, we'll have more sequencing data. We'll have a more treatment discontinuation data as well about complete responders at 1 year. How do they do? The deep partial responders who go on to get consolidative surgery or radiation. I think it answers a lot of questions about sequencing and how patients do over time. And to the point that patients are living longer, they're getting subsequent therapies. I think thinking about sequencing optimally is important for these folks.
Yeah, and I think maybe what PDIGREE is a good example where you put the trial out there and you do it and people say, oh, it's a great trial, it's a terrible trial, it's a great trial, right? I mean, I'm sure you've experienced this, right? But at the end of the day, it's going to answer a lot of questions. So I agree with you.